Hi, I'm Dr. Julianne Pollard-Larkin here at MD Anderson Cancer Center in Houston, Texas. And I want you to know that you have the power. I want to first and foremost thank you all for putting this wonderful event together and for inviting me to be one of your speakers. So I want to give a huge thanks to Dr. Njiwe Ani, the president and founder of Pink Africa Foundation, as well as Victor Ekbo, the executive director, who reached out to me personally for this particular event. Thank you so much for asking me to participate. I want to connect the breast cancer statistics that you are aware of within Africa with what we see in America. So in the United States of America, some of you may be well aware that Black women are 40% more likely to die from breast cancer than white women. And we're twice as more likely to have triple negative breast cancer. Within Africa, the breast cancer statistics are also alarming. Notably, despite the high mortality rate seen on this graph in orange compared to other nations and countries as well as continents, what you'll realize is that the incidence of 36.2 is nowhere near the incidence of what you see around the world. Meaning that although the incidence is lower than some high income areas, Africa still has an unsettling high mortality rate that must be addressed and is part of the reason why you have your Pink Africa Foundation today. So how can we build an African breast cancer survivorship plan, especially given these dramatic mortality rates and statistics? Well, I want you to know that programs within America have come up with comprehensive plans that anyone could adapt to their situation in order to help address survivorship in their nation. So one such organization is ASCO. It has several survivorship plans for several specific cancer types, including breast cancer. ASCO is the American Society of Clinical Oncology. And if you go to their website, you'll notice that they have an entire series of cancer survivorship plans. The breast cancer survivorship plan is very straightforward and it outlines how you develop a follow-up care plan for a breast cancer patient who has undergone therapy for that particular disease. Most importantly, note that you're just documenting and keeping track of all of the new items that unfold as the patient undergoes their survivorship period of time. They'll address within this documentation that is provided from ASCO anything that represents a brand new symptom, anything that would worry the patient, or anything related to any of their new scheduled clinical visits. Most importantly, they also will include lots of information regarding the cancer surveillance or other recommended tests to determine if there's any new development of cancer within that patient being provided on this survivorship plan. Also note that even the different emotional issues that the patient is undergoing as they progress through survivorship is also well documented within a comprehensive survivorship plan for breast cancer. Finally, they also will have a space within the survivorship plan to actually document any changes to their lifestyle or behavior which may impact their ability to have a longer survivorship. Now, how do you get to a place where using such a document may be useful within the countries within Africa? There actually was an amazing clinical trial that happened here within America that actually helped to reduce racial disparities that are quite demonstrable in our nation because of the way that healthcare is directly related to people's income level and unfortunately their socioeconomic or racial status. So this particular study is documented in this paper called A System-Based Intervention to Reduce Black-White Disparities and the Treatment of Early-Stage Lung Cancer. And I want you to understand, despite the huge disparities that you see for people surviving with cancer in America, this study helps to show what kind of interventions, what kind of changes you can put into place to help to reduce those barriers and give everyone a better chance for survival. And I feel that this is the type of intervention and type of trial that should be mimicked in Africa and several other nations in Africa to help to reduce the gross neglect and need that is apparently there. Now, what did this study show? Well, let's give some background. This was an American study to reduce cancer disparities. It showed to be effective in all groups, not just for those people who are marginalized, not just for the Black and brown participants. So the background for this particular study is that they had some advances in early diagnosis and curative treatment, and they realized that they wanted to reduce the high mortality rates associated with non-small cell lung cancer. But they recognized that there were huge disparities, huge differences in how well their Black patients were doing with the same type of treatment that the white patients were getting. So what did they do? They had a 5-year pragmatic plan where they looked at their 5 different cancer centers for patients who are between 18 and 85 years old who had early stage lung cancer. And then they actually did something very simple to help bring about reducing these disparities. They did some simple interventions. Number one, they had a real-time warning system derived from electronic health records to indicate, did someone miss a treatment appointment or a clinical care visit? Number two, race-specific feedback to clinical teams on treatment completion rates. They tracked to see how everybody was completing all of their treatments. Number three, they added a nurse navigator, simply a person that makes sure you're going through all your treatment and care visits the way that you should, the way that the doctor asked. These are 3 very simple, not high-cost interventions that help to reduce disparities. And so they consented their patients and they are placed on this retrospective trial and so forth. What did they notice? Let's get to the results because that's what you care about. There were 2,841 early stage lung cancer patients, 16% that were Black in the retrospective group, and 360 or 32% Black in the intervention group. For the retrospective baseline, crude treatment rates were 78% for the white patients and 69% for the Black patients, meaning that they were comparable. Finally, within the intervention cohort, the crude rate was 96.5% for Black versus 95% for white patients, bringing for Black versus white patients, meaning that their between group analysis confirmed treatment parity for the intervention. There was very little difference between those 2 groups. And so they concluded that a system-based intervention tested in 5 cancer centers reduced racial gaps and improved care for what? Drum roll. All. When you actually follow through with your patients and you consistently make sure that there is someone guiding them through the process and not allowing them to fall through the cracks because they don't meet their appointments, because they don't have the financial security that the other group may have, when you account for that and reach out for that person and fill in those gaps and increase communication, you get better outcomes. We need this, whether you're in California or if you happen to be in sub-Saharan Africa. Interventions, low cost like this, work. So I want you to know and take home some good news. This can work in Africa too. How can I say this? Because there's already been in 2016, McKinsey et al.'s team has shown a similar African trial that had notable similarities to what was done in America in 2019. So this study was called African Breast Cancer Disparities and Outcomes, or the ABCDO or ABCDO protocol of a multi-country mobile health prospective study of breast cancer survival in sub-Saharan Africa. Now, what were some of the limitations of the study? This protocol describes an ongoing prospective cohort study across 5 different countries in sub-Saharan Africa, and it uses an mHealth tool for studying management and standardization of data collection in real time. Now, they created a simple mobile platform that was utilized in order to acquire patient data. The African settings, they noticed, posed many challenges for them, including minimizing losses to follow-up care and obtaining valid information on disease progression and mortality. Now, this was a hospital-based study and did not capture experience of women who just sought care elsewhere. What I want you to realize is that during the course of their study, they recruited patients from Namibia, Nigeria, South Africa, Uganda, and Zambia, and the women were 18 years or older who had any new clinical or cytological diagnosis of primary breast cancer. They had over a 2-year enrollment period where they enrolled close to 2,000 women who in the first instance will be followed for between 1 to 3 years, and they had a face-to-face baseline interview to obtain their initial information. What did their platform look like? It was simple. It was something that patients could use on their mobile phone to allow for them to document their experiences, similar to that ASCO documentation for survivorship care plan that I showed you in the first set of 3 slides. I want you to know, when you make it simple and you make it accessible to most, if not all, through mobile platforms, you can have similar outcomes and tracking capabilities to what McKinsey's team had here in sub-Saharan Africa. So I want you to know, we've already seen 2 different trials that work either within Africa or within the United States of America. And I want you to realize that if we were to think boldly, to think more forwardly, we can close the cancer gap together. We need to work together utilizing simple technology to overcome a drastic disparity amongst cancer outcomes across the world. Thank you for what you're doing with your foundation, and thank you so much for listening to me and giving me this opportunity. May you have a wonderful rest of your day. Bye-bye from Houston, Texas.